Ferenc, this is Dr. Srinivas Kumar here. Hello, can you hear us? We can see you
hi.
now. We can see and hear you. I initially briefed, there's no problem. Here we have Ajay Kirtane.
Very good afternoon.
Yeah, Ajay, Sanjog and others are there. They will interact with you. Over to you, Ajay.
Yeah, dear friends, thank you for the invitation. We are really very honored to be live case center. And together with my colleague, Dr. Rahimi, Dr. Lufenat, we have Dr. Schmitz from ICU, and we have here Sandra and Susie as technical nurse staff. We are very happy to present you tough case. We have here a small slides introduction. I think, can we go to slides? You can comment. Go back to the first, yeah. Can you see the slides?
We can. And good to see you.
Okay.
Although I always look forward to
hi.
seeing you in person here. So on the screen is, it's great to see you doing a case, but we miss you in person.
Yeah. Next time. Okay, go ahead, Dr. Raimi.
Thank you very much. Also a warm welcome from my side. I would like to represent you our case. It's about 86 years old woman without any severe pre-existing conditions. She is a former smoker and is complaining dyspnea regarded to physical activity since a couple of months, and she has also some edema in the peripheral. Next slide, please. Yeah, the echo showed us severely reduced LV function with an ejection fraction of about 15% and hyperkinesia of the anterior wall. And we decided to do an angiography, but first I would also like to mention one really important point. The CT angio we did after the coronary angio, it showed us moderate lesions of the inguinal vessels on both sides. Next slide, please. So I would like to represent you the coronary angiography. Here you can see the right coronary without any severe stenosis. Next slide, please. After that, on the left side, you can recognize severe calcified stenosis of the circumflex and also of the marginal branch. So we have got here slightly bifurcation stenosis, and on the right side you can see the LAD, also with the severe calcified stenosis of the bifurcation. But to be on the secured side, we did also a hemodynamic measurement. Next slide, please. And here you can see the values. We had for the circumflex clearly pathological value was 0.85, and the LAD showed us on both branches pathological values. So we have to do both of that. Next slide, please. So what is our PCI strategy we had? Because of the low ejection fraction, because of the complexity of this intervention, calcified lesion, and intention to do an rotablation, we decided for a protected PCI. So our first step would be the placement of the impella CP. After that, we would like to go for the rotational atherectomy of the LAD with the burr 1.75, and if needed, we would go afterwards for an IVL2, but we would also try to decide that after an OCT evaluation. So imaging will be done by OCT, and after that we would like to do the first bifurcation. This would be the LAD and the diagonal branch. Primary, we would do one stent. We would like to do a one stent treatment, and if necessary, we would go for a two stent strategy. And after that bifurcation, we wanted also to do the bifurcation of the L6, but here also just provisional stenting.
Yeah.
And after that, final imaging with OCT, and if possible, a weaning and replacement of the impella.
It makes sense. A couple things of interest is that the degree of the cardiomyopathy with an EF of 15% seems a little out of proportion to the coronary disease. I mean, I think it's obviously a complicated case, but when you initially showed that, I was imagining CTOs and just horrible disease, and it doesn't look that bad. So is there something about the clinical picture that suggests a change in an acuity portion of it recently with this new anterior hypokinesis, or is it just she's presenting de novo?
Yeah, we believe that's a combination, probably as you mentioned, myocardial problem and additional on top coronary problem.
Yeah.
So we, to be honest, why we are a bit late, we had angiosity and we had diameter vessel in inguinal area. We had 5.3 millimeter, and it looks from angiosity quite nice, but finally you can see it was definitely not possible to go through the iliac artery. You see a lot of calcium. That's not only in coronaries, everywhere we have here a lot of calcified plaques. And finally, we use it here. Our colleague from angiology department was helping us to use here finally 8.0 balloon with around 10 atmospheres. And then finally, next step, we could manage this curve, one more ballooning. And then finally, we could go through the groin and through the iliac artery to the aorta. So the next step was quite easy. You see the crossing through the valve was quite easy. There was no aortic stenosis. This was clear from echo. And so the position is now good. We have support now 3.2 liter, and the pressure is not perfect. So our colleagues from ICU give us support as well by catecholamines. But this is, I think, at the moment, low dose support. So our
No, I was just going to say that the choice of the word support comes in, there's many ways of doing support. There's the hemodynamics, there's managing the vasculature, there's managing the sedation and everything else. And so for these patients to truly, get through these tough cases, you need kind of multiple levels of it. I personally don't like the term protected PCI because I think that it protects those people that really need it, but then other people, you're exposing them to vascular complications and bleeding risks. But the way you've managed it makes a lot of sense. There are other people who would use IVL of that iliac. It tends to probably be a little bit safer than a balloon, but this is a great way of proceeding. And one thing you don't want to do is you don't want to stent the iliac and then take the impella through that because a cage can get caught on it or otherwise. So this was well done.
Do you have any right heart cath numbers for us? I see you have a Swan-Ganz catheter up.
Yeah,
but
we have.
How did you use the hemodynamics to make the decision of what type of support to choose and why?
This is very helpful. This is very helpful to make the right decision at the end. Can we go out with support, or should we continue support to the ICU? But we just check the pressure before, check the pressure, pulmonary pressure and diastolic pressure during the procedure. And we started now, I think, with LV-EDP was around 12, right? So patient is now in stable condition and compensated. So that's a good sign.
That's a good sign. I think one thing
we go now.
Keep going, sorry.
Yeah.
Sorry.
Yeah, what we have to be a bit faster because we have just probably 1 hour slide. So I wanted to go direct with rotawire drive, but it was not really nicely working. That's why I use it now, a simple wire, floppy wire to bring microcatheter down. And we go now. It was difficult to cross even with a micro. It was fine cross. That's why we go now with rota drive and start direct rotablation. The question is, would you start with 1.75 or 1.5? That's a question.
Yeah, I mean, my preference with this angulation is to typically start with a 1.5, and
I think you may need bigger eventually, but I'd probably start with a 1.5 here because you're going to end up making yourself some room. either way, you're
Yeah,
going to have
that's-
to you're going to have to address that
Yeah, we have-
bifurcation with a secondary balloon. Miroslav, I don't see your hemodynamics up. We don't see a pressure trace. We see what looks like the end of a pressure trace, but it's either zeroing or zeroed or not transmitting. I can't see a waveform.
So we have now pressure around 64, so the pressure is really not good.
Yeah.
Impella give us support, so patient is fine. Oxygen.
So I see that you've also got a lot of ventricular stuff going on. It's sort of runs
Exactly,
at 4 or 5
exactly.
beats. Is that the
1.5?
device too deep
Yeah,
or?
1.5.
1.5.
No, we checked this by
Looked good, but
pigtail, but
Sort of
looks
statistically
was
the
fine.
most
Maybe
common
I'm
reason
just
for
going
these
a
runs?
bit. Yeah, that's a good point. Yeah, I think the position is, as you can see here,
looks a
I
bit
think
deep.
position is maybe a bit back.
And with the CP, when you turn it on and it sort
It
of
always
ramps
goes
and
forward.
then goes in a little bit. So you
Yeah.
have to be cautious with that. And the second thing that can happen, less so with the left, is you can get interaction of the guide
Yep.
with the device as well. So you have to be cognizant of that position.
Yeah.
Because sometimes, honestly, with the VT, with a bad EF or not even just ectopy, you can get the patient decompensating
Oh, yeah.
because of the ectopy. But that's why that right heart cath in the beginning is very helpful, because if
Exactly.
the patient's compensated and then you turn it up, you're going to suck the LV dry. And so if the patient gets hypotensive, you might actually, in some cases, either need to give fluids or turn the flow rate down.
Yeah. I think on that note, I mean, we worked on an algorithm here, right, in India a few years ago that's in Asia intervention now that is a little bit more conservative than the algorithm that they use, I think, in the US when they make decisions on whom to implant and whom not. And hemodynamics are a critical component of that algorithm, and that was done intentionally so that people would actually get that information and learn to use it both up front as well as part of the weaning paradigm.
For
We
the
lost
AV
the case here. Can you bring that up on the monitor up front, please?
Can you maybe show the
There we go. We have the pressure trace as well now. Let's go.
Mathieu? Could you go to the table to show the rotablator?
Can you change the monitors? Can I see the case on the monitors? Right now I'm seeing slides.
I just see, we just see live case 3, just the program slide.
Mathieu, you can.
Yep. Yeah, so we see.
We can see you on the main screen, Miroslav.
Okay. So you see here our system, RotaPro system, which we have here in Germany, and put it here and make a test. So we test for, we go to 175. So we usually rotablate here with 175, a bit less, okay. And now Dinah, first Dinah.
So what
Okay.
you're seeing
So
for the
it's-
audience in real time is what Sanjog just demonstrated in the last session. So Miroslav, we just had a Rota demonstration literally like an hour ago. So this is perfect.
Yeah,
Really
yeah.
nice to show
Okay.
it again.
So we go now with Dynaglide, and there is, you see, it's very smooth movement. And we check the wire in position, wire's perfect in position. And so, stop.
So see,
And,
single
what
operator,
I
nothing moved, everything was good. One caveat
exactly.
with that though is when you go into the TUI, you need to make sure that the wire loop is expanding. I actually had a case 2 weeks ago where that didn't happen because the brake was not fully defeated, and I ended up with a huge loop in the aorta. Luckily, I recognized it, but I had to restart again. So as long as the loop is expanding, you can just advance it all the way up, and now he's platforming and getting everything ready.
So we have already ACT over 250. We have now a pressure which is now around 120 to 80. There is heart rate is around 80, so we can start to rotablate. And if there will be some bradycardia, then we give on top atropine. So we don't have at the moment pacemaker.
And you should probably be okay because the right is big and it's open.
So short runs around 5 to 10 seconds, not longer, and give some time, we can check the flow. We have 7 French, EBU 3.5.
But I also like the guide position because, I mean, right now you've left it kind of disengaged, but that's good because the hemodynamics are not favorable. If you need it, you can put it in later. But these techniques are really important because even with support in the decompensated patients, you need to short runs, get the guide out, and let the patient breathe.
We discussed this concept of hemodynamic load, right? So every one of these cases has a hemodynamic load associated with it. How many balloons you put up, how long you hold them up, how long you do atherectomy, whether your guides are engaged for extended periods. If you're doing a CTO, is your retrograde guide disengaged for a period? Are you able to hemodynamically optimize them before the case? All these things that we can do to reduce hemodynamic load, I think, can inherently make the procedure safer. You know, with disengagement of the guide when you're not using it being one of them to prevent that aortoosteal stenosis that you introduced.
So you see, we tried a few times very gently. There was initially clear resistance, but finally with a packing technique, forward, backwards, so we could manage this part quite nice. We go back again with glide assist, so you can see how we are doing this. Normally I'm a single operator. You just press and go back. And you see the wires perfect in position.
Stop.
Okay, I have it.
Stop.
Okay. So we would like to go now with OCT and wire diagonal branch.
I think that sounds great.
So maybe just to show how it looks, flow is okay.
And then you're going to swap that rotowire out for a workhorse, or are you going to work over the rotowire?
No, we just remove. We place standard extra support floppy wires. So you become a run through, Samurai and Grand Slam. I think we need here definitely good support, good backup. We wire now the diagonal branch, which is not so small and should be kept open definitely.
Do you have the wiggle wire there? Is that something you have access to?
No, we don't.
No, we don't have it.
It's a very old anchor wire for the audience here with an exposed coil tip that sort of bends and undulates. It was made by Abbott many years ago. It has the body of basically a Grand Slam, but with an exposed coil tip that grabs the outside of the vessel where it is in the distal vessel and provides a beautiful anchor for just cases like these.
Yeah, okay.
But not one that you would typically use as a primary wire, right? You'd have to swap that out.
We go to epicranial position, try to get now wiring of the diagonal branch, and then put Grand Slam to. There is a quite large angle, application angle.
Large angle, it's a large diag that's very important to the patient. So
yeah, definitely.
I think
okay, now Grand Slam.
That's the type of diag that if it were to shut down, the patient might get very sick.
What is it? Yeah. Okay, so we take now Grand Slam, and then if Grand Slam will be nice in position, then we remove rotor wire from the LAD. And I think I wouldn't go with, let's see here. Kannst du das nass machen? Make it wet.
So there's some people who, what they'll do if they think they may need to upsize the burr, is they'll wire with a second workhorse wire and leave the rotowire down, do some ballooning, do some imaging, and then if they need to, then they can go up with another burr. But in this case, you have to keep moving efficiently. You wired the diag already, so you're probably not going to roto this LED again unless the OCT really looks terrible. So for this case, I think the way that you're doing it's right.
Exactly. I think in next step, if we need more debulking, more sufficient lesion preparation, I would go majority of cases with IBL. So we have now at least for sure 1.5 channel TOCA.
Yeah.
And then we could go easy with
NC balloons and whatever.
orbital NC balloon and shockwave if needed. So I'm just trying to catch a good lumen.
And that's the Grand Slam?
That's a good.
That's Grand Slam. If we have problems, then we remove, prepare
the
micro, and then we. Okay, that's some problem. I don't like to.
No, it's very hard to wire
whatever.
primarily with the Grand Slam.
Yeah, it's not.
So we go now with micro
you feel everything.
Over rotawire and exchange to Grand Slam. I think it makes sense. Normally it's going.
Maverick 2012, bitte.
We know there's this patient is old, so we have to manage this problem by interventional cardiology. There is no option to go with surgery. I think this is what we discussed already here in heart decision. Just to.
Speaking of that decision, so when you set this case up, do you get anesthesia involved early? Is the patient awake, or is the patient
is awake. This is just simple sedation now. I think with now at the moment we have propofol, right? Okay, Dextor, and patient is now sleeping. So very, very nice condition. So we have in background ICU team. Taking care
Grand
of the
Slam hast du schon
patient.
rein, ne?
Grand Slam.
I ask because if you look at your aortic tracing, every fourth beat, your aortic amplitude drops, right? So that's probably when the patient's breathing in. And it's either severe LV dysfunction or more likely some degree of vasodilation from your sedation and less flow, right? And, as an interventionalist doing this type of a case, which is a complex case where your head's going to be all about trying to rebuild the arteries, it's nice to have the help of your ICU physician or an anesthesiologist to manage the sedation and manage the hemodynamics around that, such that you're not getting stuck with suctional arms and such.
Absolutely. So we have to treat here very sick patients who are really sick in poor conditions. So that makes sense to have here good backup.
We're learning more and more that these are about team-based care models.
Exactly. So we just trap the micro, okay, 18. Okay, so fine cross is now outside. So now we can go with imaging, negative. Okay. So, okay, so I think we have here Dr. Löffelhardt, who is in background now giving us support for imaging. So that's OCT. Creatinine is still okay, so we can do this. We can do one shot with contrast, one shot with saline, maybe one to compare how with the quality. You had today morning very nice session according imaging modalities.
That's right, and actually, and Akiko is on the panel as well, so it's great.
Yeah, fantastic lectures. Thank you. So we can cross some resistance.
Nice.
Okay, but now we could cross. Fine. Okay. So, did you flash here?
I already flashed.
Okay.
Ich hatte schon gespielt. Ja.
Did you flash? So it's take a look, and Akiko is in the panel.
She is.
Yep, she's right here.
Oh, great! She can make a comment.
I'm ready.
She's ready.
Okay. So you step. Can we? Jetzt, ja. Maybe we were too deep, probably. Yeah, we were too distally. So distally, the vessel looks not so bad.
At least you know there's a long normal zone beyond your diagonal branch.
Yeah, I
Yeah,
don't
yeah,
see,
okay, we have to.
we don't see the
Yeah,
lesion.
we were too
This
deep.
was super nice,
Okay.
normal.
So we go now.
That's a good place.
Yeah. We go a bit back and welche Länge hast du? Welchen Segment? 54?
Oh, jetzt ist doch gut.
Probably now it's good. Okay, once more. So we are now in proximal part of the vessel. Can we go? Yeah, okay, flash. You tell me if I'm ready.
Yeah, that's nice.
Now it's better.
So starting the mid segment, the chat artifact, that's
Yes.
a calcium, and that's a nice rotability effect. That's, yeah, that's quick. Okay, so that's a very proximal left domain. It's clean. Go back to the region, and that just distal to the region. Coming back, that's calcium. It's not too bad. It's only 180. That's a place you see the 3 o'clock. That's a nice rotability effect, but that's dissection. And then coming
Yeah.
more,
Du kannst sonst mein Mikrofon haben.
yeah, just like the eccentric calcium.
But this is critical
Yeah.
part here.
Yeah,
And,
so
what do you believe? Are we here sufficiently prepared? Probably we need now. We have some.
yeah, that's a
Cracks
place.
in
Okay,
dissections.
okay. Yeah. So go back to a little bit distally. Come back.
Go to distal.
Distally. Here. Yeah, too quick.
Sure.
So go back to the
Können Sie
proximity.
Seine Kopfhörer ihm geben?
This is like
wenn Sie
stereo
ihn
vessel,
haben?
media to media. Come back. It's only eccentric plaque. Come back more proximally.
Yeah, just Akiko, wait a second. We give the micro to Dr. Löffelhardt. So Nico, can you hear?
So, no, I don't hear anything.
So now, Akiko?
Yeah, yeah. So this is a distal segment. Its vessel size almost media to media is 3O and only eccentric calcium. Go back. That's still eccentric calcium. That's a place. Yeah, you see the calcium. This is just flap. I see very eccentric calcium here. That's perfect. Perfect. Here. You see, like the 3 o'clock, 6 o'clock. That's nice, polished by rotablator. You see the very nice round shape. That's really the rotablator polishing the surface. It seems to be protruding calcium. Probably this is non-eruptive calcified nodule, which you polish on the surface. But I do think the overall calcium was actually not too bad. This portion was only, I see the nice rotablator effect. So I think the next step is just balloon, I guess.
NC balloon, yep.
Yeah. Can we have a diameter distally, Nico? What is, I think it's around 2.5, 3.0?
Yeah, Akiko thought it was media to media,
Close to
more
3.
like 3, but
Yeah,
It's pretty
I
re-
would suggest to take 3.0, Quantum 3020.
because that's
So,
lumen
okay.
right
Yeah,
there.
that's a lumen.
Mathieu, could you make OCT bigger as a first choice on the screen?
Yeah, that's much better to see.
Yeah, thank you.
Okay, I see much better. Yeah, I think close to 3.
Thanks.
So that's a lumen measurement. And lumen's area is 7.2. The lumen diameter means 3O. So at least the vessel size should be larger. So if you use a lumen measurement to decide the balloon size, we are upgrading quarter size at least. So I think 3O non-compliance seems to be a
So
problem.
we have We have already 3.0, so father is
great.
just going up to 12 atmospheres. This is now, I think, sufficient.
Yeah, it looks expanding
sufficient
nicely.
opening.
Yeah.
Negative. So I let balloon in position and make some gently test. Yeah. So maybe here again, so 8. Negative. Guiding is too deep. So I think we go again with OCT and check this by OCT, and probably hopefully it's fine. Then we can go ahead with the stenting.
What about
Yeah.
the diag? Are you going to do the OCT for the diag or?
Do you plan on imaging the diag?
I
We
didn't
want to stop with proximal stenting. We will stop at the diagonal branch, at the septal branch. There's a septal branch, and I think we shouldn't go over septal branch. We can make now one more projection. I think it looks now much better. And the diagonal branch is still open, and I would stop. Maybe you can, Nico, can you show me on imaging that the lumen or by septal branch?
That's a septa on the 12 o'clock. I see the diag is actually 9 o'clock, which is super clean. That's one. That
Yeah.
looks like the diag. Ostium of the diag is super clean, so it looks okay.
Which is great.
Simple provisional stent, hopefully.
I think in this case, we initially we believed maybe double stenting will be good, but imagine this lady has a really poor LV function, and we know double stenting or LV function in general is a predictor for stent thrombosis.
Absolutely.
Particularly if you have two stents solutions. So we try to make it simple. I think that's a really provisional approach now. Only if needed, then we can convert to Dickey culotte or to TAP. I think this is. I hope you agree with this.
We all totally agree with you.
100%.
And just for the audience, in terms of the OCT measurements that you're seeing, this is all lumen-based. And remember, you can do it two ways. You can do it lumen-based or you can do it vessel-based. If you're going to do it vessel-based, media to media, that's more akin to IVUS. If you're going to do it this way, you have to then go up a size in terms of everything you do. If you don't, you're going to grossly undersize your stents.
Versus going down a size if you're doing it the IVUS.
Yeah.
So the point is we have two options. We can start with 3.0, stand distally,
Correct.
and take then 4.0 to the proximal part, have some overlap, or we can go just with Onyx 3.0. 3.0 can go easily over 4.0 for this
That's right.
proximal parts.
That's exactly
Yeah,
right.
I think this will be the best option. How long is the lesion from the septum to the healthy? I think I would go here with around 34. Do we have here Onyx 3.0? 34. Okay, so we take Onyx, and this is diameter according to the distal part, and of course we could learn from Akiko's lecture today. In LAD will be proximally, of course, much larger from diameter, but we have now chosen a stent which, with a good radial forces, with a good access to the side branch, and we can postulate up to 4.5. Thank you. So we go now on the Grand Slam to the distal, to the LAD. There is still diagonal branch wired by a floppy wire, and for safety, this makes sense.
Makes a lot of sense.
The wire.
Indeed.
So I'm going now with the stent, which can cross very easy.
I mean, that's the
Good
difference
sign.
between, atherectomy and not atherectomy,
Yeah.
is that
Yeah.
Exactly,
it just
exactly.
goes.
Even if you have some tortuous vessels, it makes huge difference. So I would go now here. We start here. So we have around 8 millimeters to make final pot. Okay, 2, 4, 6, but very gently, stepwise. 2, 4, 6. So we don't crush immediately. The vessel wall, we stretch very gently. 6, 8, and 10. That's fine. I think stand open quite nice. Of course, we have now negative malar position proximally, but we will cover this with NC balloon. Okay, can we have now 8 millimeters 4.0 first? So we go now with a short NC balloon, 8 millimeters 4.0 to achieve hopefully sufficient pot maneuver. And then we will also go to the distal part to make distal optimization, dot and pot. Then finally,
No, I think that sounds,
yeah,
and
So
I
this
think,
is the sizing is perfect because
Sizing
this is 30 millimeter, and you remember this was 3O, and he chose the proximal is 4. That's perfect. It's 1 millimeter taper, and because of the big diagonal septal.
yep. So, and then Miroslav, so time-wise, we have, I think, about 5 minutes left. So maybe the pot.
I see the pot, and then and then another OCT run after we're done to check.
okay. Yeah, sorry, we
No,
it was
it's
really
actually super
tough
helpful.
to
No, no,
place
it's fine.
impella, but safety first.
And we can always come back,
Of
to your
course,
finals.
this will be great. So sometimes we also use here this clear stand or stand boost option,
Yep.
468. This is sometimes very, very helpful. You can see that's perfect position.
Very nice.
12, 14, 16, 1, 6. Okay, negative. So just safety check, but the flow should be fine. Yeah.
Oh,
Okay, so we
That's
go
great.
back and go now with OCT, and then we continue to work here, and later we just maybe have option to show you final result.
that's perfect.
Perfect location of that post-tilt balloon too, right? With the distal edge of the balloon right at the level of the bifurcation, so you get some of the strut bowing towards the diag in case it becomes an issue. It becomes easy to cross into. Optimizes the side cell size.
Okay, so we go now with OCT. And can we have BGA und ACT again? So we check ACT one more time. Yeah, between there was some drop with pressure, but finally we have now stable patient on the table. We can do our good interventional job.
And I think because this has been efficient, moving smoothly,
Okay.
et cetera, and the support is in, it makes sense to treat the
comfortable with the
circumflex in the same setting.
Yeah. Yes.
Many times, though, there's been this push to do everything at the same time. You really have to just know how much insult the patient is taking,
Exactly.
how long it's been, especially given their age. But this is moving very smoothly.
How do you measure that, Miroslav? Or how do you measure that?
It's
Anybody
a
on the panel?
feeling. It's kind of the more restless
That's
the
a
patient
feeling.
gets.
That's yes.
So one of the things
think-
that we worked on with Barbara Bashir was, especially on these impella-associated PCIs, is the number of loss of pulsatility episodes.
Yeah, that's
So the more loss of pulsatility episodes you get, the longer you are likely to stay in the
Große Spritze.
ICU, where any more than 3, you dramatically increase the number of days in ICU and your 30-day outcomes get worse. But what I have found is that the longer you end up doing the procedure, the more of a SIRS response they get.
Yeah.
So you start getting a rising PA saturation and you end up with this weird bimodal shock picture where the heart's stunned and so it can't augment contraction to deal with vasodilation,
You get
and at the same time
vasoplegic
you're
too, yeah.
vasoplegic. So that's a sign to stop.
So the OCT show distal edges looks fine, And this is going to be, okay, this stage we just, there is some haziness by angio, but there is some calcium. Stent expansion looks nice, and we don't see the proximal edge, but
Yeah.
overall, for now, looks okay. Distal edge, okay, so that's a supradistal. This is chat artifact, this is just artifact. This is artifact 9 o'clock, this is not dissection, this is artifact. Coming back more, still this is a lot of chat artifact. But I don't see any dissection yet. Coming back, that's really edge. So edge looks fine, and landed okay place, and then that's all. Yeah.
But I think we have, do we see a sufficiently a proximal part of the stent?
No.
No, we didn't.
No, we
No,
don't
no.
see. Yeah, so
We
we have
don't
to
see it.
repeat this. We're just back, and can we start again? One more? Just a second, then we will be at least with the imaging ready. Okay, start.
Moment.
Just a second, we just load again. Okay. I can go now.
Wow.
Okay.
Now it's much
Approximate
better.
Lovely.
looks nicely
Looks
apart.
very nice.
Yeah.
Lovely, nice.
So I think there is not huge malapposition.
No, not at all. And that's a
underexpansion.
nodule which
The
we
nodule
just
got
passed,
pushed aside.
and that's a diag, and proximal portion, that's port segment, and no edge
Yeah,
dissection.
looks great.
It's good.
Beautiful, you're down there.
I think we see the diag segment here.
Oh.
That's the left main come back. That's proximal already. Go distally. Go. That's a proximal. Go. That's a proximal edge. Nothing.
Oh,
that's
that
a
looks
velar
nice.
pause. Go. And you see the diag soon. Go. That's
There.
a diag.
And it's
in the
wide open.
12 o'clock. 2 o'clock, it's good, and that's distal. I think you may want to dilate a little bit more distal, that segment, which nodule segment,
Yeah.
which you didn't
Yeah.
post dilatation yet. But overall,
Yeah.
it's good.
Yeah, we will do this now as
Yeah.
next step,
So-
post-dilatation distally, and probably gentle kissing with a huge diagonal branch, and then we go
I-
to circ.
I personally wouldn't kiss. I think it looks, I mean, it's opened by OCT.
Yeah.
The flow looks
Timmy
fine.
flow.
You know, I would probably leave it.
And
But
there's potential jeopardy for injury to that diag.
You're
Right.
right.
Especially when there's no
and you
disease on
deform-
the...
And you deform the
Yeah.
LAD stent.
Yeah,
So-
there's no disease. You have stand to deform the stent, and if you end up bailing to the 2 stent, as you pointed out, there's jeopardy in that.
Yeah. But
Yeah, that's correct.
You keep working. This is an amazing demonstration,
It's a really nice
especially
case.
right after
Yeah.
this demo from last session. Great work, and we'll come back to you to see your final result. We're going to move on to the
Okay.
next case, and we're going to switch the panel as well.
Matthias, change the plane. Okay, so see you later. We
Take
just
care. Thank you.
continue
Thank you.
to work.
Great
Nice
work.
case.
Yeah, thank you. See you later.
Hello.
Wenn ich die rausziehe, dann...
Hello, I'm Dr.
Yes,
Ferenc
sir.
calling from Hyderabad, sir. Can you hear me? Hello.
I don't think yes.
Hello?
Yeah, we can hear you, sir. I was told that you wanted to show the final result. We're back with you for 5 minutes from Hyderabad.
Yeah, should we go live and present our final result?
Yes, sir. We can see and hear you well. Go ahead and show the final result.
We don't hear you really good, to be honest.
There's not,
an echo.
Mathieu, we don't have really good connection.
Please go ahead and show, sir. We can hear you well and see your pictures.
Okay, we should go ahead, I understood.
Okay. So we stopped at our case when we just were ready with LAD. The next step was, can you see the pictures?
Yes.
Okay, wonderful. So this was final result for the LAD. Then we wired, this was LAD. And we have done the steps like suggested, distal optimization, proximal optimization, diagonal branch, still TIMI3 flow, so we leave it like this, then wired circ both branches, fibrillated with 2.5 and C balloon. And finally, we had in OCT run a quite very acceptable result, no huge dissection. So finally, this was OCT, finally we went to use, there was some spasm in this obtuse marginal branch. Finally, we went to use drug-coated balloon for this distal circ, and we have done this. This is 2.530 prevail with 14 atmospheres for 45 seconds. Finally, we had very acceptable result, and again here in caudal position projection. So finally, we performed one run more from obtuse marginal branch to left main, and this was very acceptable, no low limiting dissection. So we leave it like this, so we could finally manage this case with one stent and one drug-coated balloon. So both bifurcation are, we believe, definitely sufficient treated. And the next step was to remove impella, place the IMA in the iliac artery, and we could go back with impella support. So we checked pressure, wedge pressure was 21 between during the procedure, and now again 20, so we can be quite sure patient is now stable with a pressure of around 110. Yes, so it's really a sufficient situation, and we have now to remove the pump, and you can see the guiding or sheath is still in iliac artery, but we have some dissection, and that's why we ask now angiology guy to Dr. Nori to check this angiographic result for iliac artery with us. Maybe to leave it like this, maybe to stent. I don't know what we will approach now, but by coronaries we are now absolutely stable. Impella is now outside, patient stable, and we have just to check the situation with the iliac artery. And it was initially extremely difficult to go through iliac artery because of tortuosity.
Are you? What is your decision here? You're going to try to wire it, or are you going to watch and see, or?
We have already wired, so the wire is now from distal, as you can see here live. And if I just inject one more time.
Yeah, can you pull the sheet back a little bit more, Miroslav? This is Ramesh. So when you do the injection,
Hi, Ramesh.
yeah, pull back the sheet more, yeah, so that we can see. Yeah.
I think there's probably the need for stenting.
Yeah.
So we have here Dr. Nori in the room. I think that's very clear. We have to go ahead with one stent more for iliac artery.
Yeah, I think this has to be ballooned or got the vascular surgeon in the room.
Yeah,
I think this is very important to establish
exactly.
flow.
We have it here balloon. So can I have it? Okay. So we go now with a balloon. Dr. Nori, our angiologist, what do you believe?
Miroslav, this is Dr. Miroslaw here. I think you can work in peace. I think depending upon situation, we balloon it and then put a stent later. But excellent.
So which 7 millimeters?
And these problems happen.
9 by 60. Okay.
We need to break with you, and congratulations for excellent demonstration of the chief impella case. Can you hear us? Thank you very much. Give you a big round of applause.
Okay.
Thank you. Everybody appreciated it. Thank you.